Okay, well, I think in the interest of time, it's according to my computer, it's 4 after. So I think in the interest of time, we will go ahead and get started. So welcome everyone, good morning. My name is Stuart Gansky. I'm a professor and the Associate Dean for Research in the School of Dentistry at UCSF and the director of our Center to Address Disparities in Children's Oral Health. Today's poster session is focused on non-COVID issues and health disparities and during the pandemic. And our first speaker is Chung, who will speak on system-level interventions for tobacco use in a safety net health system during the COVID-19 pandemic.
Awesome. Hello, everyone. My name is Chung. Thank you, Stuart, for the introduction. I'm a research analyst at the University of California, San Francisco. And as Stuart said, I will be reporting on our team system-level interventions for tobacco use in a safety net health system during the COVID-19 pandemic. Okay, so a little bit of background. During the COVID-19 pandemic, we saw a shift from in-person care to telemedicine, which made it challenging to provide smoking cessation care. And for our objectives, we used quality improvement interventions to adapt cessation care for telemedicine and focused on delivering cessation care to our African-American Black patients who had higher smoking rates than other patients. This project took place between March 2020 and March 2021 within the San Francisco Health Network, which is a network of 13 primary care clinics. And our team developed a disease registry within the EHR, which included over 3,000 patients who smoked and had a condition that increased their risk for COVID-19. We then trained clinical staff, including medical assistants and healthcare providers, on how to use this registry to deliver smoking cessation care. And we looked at 3 primary outcomes. We looked at tobacco screening, healthcare provider counseling, and best practices for cessation care. We defined best practice care as patients receiving at least 1 cessation service during a clinical encounter. Lastly, we also looked at whether best practices differed between our African-American Black patients and other patients. So Tiffany, if you zoom into figure 1, we can see that in February, the month before the start of the pandemic, 99% of the primary care visits within our health network were in person.
Kara, sorry, I can't zoom in, but for those participants, you can zoom in via your Zoom.
Oh, that's cool. I did not know that.
Yes.
So we all zoom in together, no worries. At figure 1, in February, just before the pandemic hit, 99% of our visits were in person. And in April, a month after the start of the pandemic, in-person visits decreased to 40%. And with this shift, you can also see that tobacco screening declined from 73% to 31% between March 2020 and June 2020. And then between June 2020 and March 2021, you could see that tobacco screening increased from 31% to 57%. And then I'll be moving on to figure 2, shows our healthcare provider counseling. We saw that counseling decline from 18% to 14% between March 2020 and June 2020. And between June 2020 and March 2021, we saw counseling increase from 14% to 20%, primarily due to the increase in counseling delivered by telehealth, as you can see by the dotted line. Now I'm going to move down to figure 3. Figure 3 shows our best practice for cessation care from June 2020 and March 2021. Overall, best practice within the network and then the San Francisco Health Network was 47%, and best practices differed between the 2 patient groups that we were looking at, 43% for African-American Black patients and 49% for other patients. We also saw that clinics that served higher proportions of African-American Black patients delivered best practice care at half the rate compared to clinics that served lower proportions. So in conclusion, clinics that served higher proportions of African-American Black patients are in areas that have been heavily impacted by COVID-19, and staff there had to be deployed for COVID-19 related operations. And these clinics may need additional support to improve delivery of cessation care. Lastly, telehealth adaptation to the EHR may be associated with increases in cessation care delivery. I'd like to acknowledge the Tobacco-Related Disease Research Program for funding our project, and we have no conflicts of interest to declare. Our community partners are also Zuckerberg San Francisco General Hospital and the San Francisco Health Network. Thank you.
Okay, Sarah. The poster is now open for questions. We have about 5 minutes for Q&A in the schedule. So please, if you have a question, use the raise your hand function so I can recognize you, or unmute yourself. I think we're a small enough group that would work. Have one chat of praise and regrets of needing to run. I will go ahead and ask a question. So first of all, thank you for great presentations, very clear, an important topic. And so sort of a general question, and that's, you saw this big switch from in-person to telehealth visits, and then kind of slowly moving back to not quite equal, but closer to where it started pre-pandemic, I'll say. How long do you think it will be before we will know what the real sort of new equilibrium will be for the balance between in-person and telehealth visits? And what are some of the learnings from having to make this switch very quickly? And what would be some things that you think should need to be refined to make sure that telehealth visits are providing the same quality of care?
Thanks, Stuart. That was like 3 questions in one, so I had to mentally write a note. So the first question, how can we tell? That's a little bit of forecasting, and I'm not quite sure I can answer that. Currently, I feel like the proportions, we are leaning now more towards in-person care, and that leads to answering your second question is the reason why we are trying to bring our patients back in is telehealth was amazing. It definitely allowed us to continue delivering certain types of care via telehealth virtually. But in terms of preventive primary care, a lot of things were missing, like patients had to come in for breast cancer screening or diabetes eye exam, and all of these things we can't really, lean on the patient to get access to the machine themselves at home, or there are challenges to these types of screening. So we have tried to bring more patients in, especially those who are behind a lot of their preventive care. So just from what we've learned so far, I feel telehealth is great if there are for cases that face-to-face versus virtual conversations, or initially within our network, it was mostly telephone calls and less so video chats. So if, let's say, like health coaching, maybe tobacco cessation counseling actually was a great way. We were able to continue that, delivering that care. But otherwise, I think we're still trying to do a lot of trial and error in what would work best for our patients. We do try now that whenever we know that their in-person visit is so valuable. So what we are training staff and just continuously messaging them is to try to get in as much of the screening and deliver as much care as they can within that one clinical encounter.
Great, thank you. Are there other questions? If you have a question, you can put it in the chat. If you're feeling a little bashful, you can put it into the chat directly to me and I'll ask it for you. Oh, there's a question. Do you have any hypotheses on why screenings actually increased with telehealth? Great question. Thanks.
Yeah, so I would say that more so, I think it was more so our efforts to integrate. So within the staff workflows, we did try to integrate tobacco screening specifically in every possible way. So an example would be if within the network, we use this registry mentioned in the methods to do proactive telephone outreach calls to our patients, especially those who are at high risk for COVID-19. And in that outreach script, we've included tobacco screening. So that would be one way. And even before COVID, that was our standard of care, was trying to get everyone screened. The Pay for Performance, so a huge grant that funds San Francisco Health Network, a quality improvement incentive grant, includes tobacco too. So this has already been something that we have tried to work on before the COVID-19 pandemic. It's just a little bit of just staff becoming more comfortable with the workflow, and continuous messaging, working with leadership, I think really helped increase the screening during this crazy time.
Okay, great.
Thank you.
Are there any other questions? One more question. What were your main insights around whether best practices differed between Black and other patients?
Yeah, so we did look at, thank you for the question. Yeah, we did look at the clinic numbers individually as well as across the network. And you can see in figure 3 that the columns, the colors, there aren't like a dramatic, a very big significant difference. So we did notice that the difference came in among different clinics, not within one individual clinic among their patient population, if that makes sense. And looking into that, we are hypothesizing that maybe these clinics that did have lower delivery of best practice care in general, so maybe in the 40% range, those clinics are located in areas that were heavily impacted by COVID-19, and a lot of our staffs were actually deployed and had to support COVID-19 related operations across the city and county. So we thought maybe that could be a contributor to delivering fewer cessation care just within the clinic, versus clinics that were overall at an 80% rate were able to deliver care to both patient groups.
Okay, thank you. I have one additional question. So your figure 3 shows.
Hi, so I'm able to present the poster.
Oh, okay, thank you. Just lining up some logistics for the next one. So I have one more question before we move on. And that is in figure 3, you're showing differences in counseling among, it looks like 14 clinics, including San Francisco Health Network. And for that time period of June through March. And I'm wondering if if you pooled them together, if the counseling rates differed at all, or if you've looked at this for the African-American Black patients versus other patients over time, similar to the figures 1 and figure 2.
So pulling as in looking at it in an entire one denominator over time?
Yeah, so if you put all the different clinics together,
Yes.
and you had looked to see what the pattern of counseling might have been over by time, similar to figures 1 and 2 for the 2 groups.
Got it. So seeing weekly delivery of cessation care between those 2 groups over time, instead of lumping it right, looking at it from June to March right now, has what the figure 3 pretty much shows. Yes, we do look at that in terms of actually our quality improvement efforts. In terms of presenting the data, we thought it was best to just count each weekly delivery, just to add it all up, and which is why it came up this way. And adding it all up did show that overall within the network there is a difference. So 43% we delivered cessation care best practice cessation care to our Black African American patients 43% of the time versus 49% for other patients. So in response to that, we have been doing more targeted outreach telephone calls to deliver coaching, counseling, motivational interviewing counseling for our Black African American patients. We've also continuously worked with our leadership to just share this data and really empowering the individual clinics to take on their efforts to improve health equity and to just improve care and in delivering tobacco cessation care. So yeah, we're still looking at it on the network side weekly and monthly. And good news is we are inching towards closing the gap. So yeah, it's been helpful overall just to continue working and improving our cessation care delivery. Am I the one frozen or is it Stuart? Oh no.
It looks like Stuart is frozen and have signed off. So I'll take over the facilitation. If there's no more questions, we'll move on to the next presenter, if that's okay with everyone. Okay.
Sounds good.
Thank you so much, Kara.
Thank you.
The next person, let me move my screen. Looks like Stuart is back.
Hello.
Hi, Stuart. Can you hear us, Stuart?
Can you hear me?
Yes, we can hear you.
Okay. Sorry, my connection seemed to have dropped, but I'm now using my phone.
We're hearing a lot of echo from you.
Yes.
Okay. So, Stuart, I'm just helping out while you're stepping away, and we have finished it up with Kara. So I'm moving it on to the next Kara, and I don't know if I couldn't see this presenter is on, so I'll let you take over again.
Okay, thank you very much. Sorry for that disruption. Haven't had a problem yet with my Wi-Fi where I am, but of course, Murphy's Law. So thank you, everybody. And thank you again, Kara Chung, for an excellent presentation. And Q&A. I asked a couple extra questions because I know we don't have, one of the speakers is not going to present. But we do have our next poster queued up and ready. So our next poster, the first author is Kara Lugtu, is addressing disparities in breast cancer screening, Black African American women during COVID-19 pandemic. And pinch hitting is Niharika Dixit, and I hope I have said your name correctly. And extra kudos to you for stepping up and being willing to pinch hit and jump in to present your research. So please.
Thank you so much. It's Niharika to allowing us to present this work. And so this work is out of the San Francisco Cancer Initiative, a partnership between UCSF and the city of San Francisco, and with the overall goal of reducing the burden of cancer within San Francisco City. And so this is from the Breast Cancer Task Force. What we know is that in San Francisco, women who live in communities that are low income and high diversity are more likely to present with higher stage at diagnosis, specifically more likely to present with lymph node positive disease, stage 2B and above. We also have seen from the data from CDC that the same neighborhoods are also likely to have lower utilization of mammograms. So what we did was we looked at the San Francisco Health Network across all the clinics in San Francisco Health Network And we found that African American women have the lowest rates of mammography screening, less than 50% in overall, even pre-pandemic. I'm sorry, less than 58% or so compared to 67% for other women. This number was specifically decreased during the COVID-19 pandemic, and the number for African American women went down to less than 50% at some point in pandemic. So there's already a pre-existing gap, but that gap was even increased during the COVID-19 pandemic. So what we did, that quality improvement is a methodology to improve cancer quality of care, quality of cancer care, quality of screening. And we decided to do a quality improvement initiative, specially focused, that would provide a tailored outreach. So we call it as equity-focused quality improvement, because if quality improvement does not take the equity consideration into account, it will never decrease the gap, even though it may actually improve the quality of care overall. So the gap will still remain. So we realized that. And these are the numbers in September 2020, between all RFPC patients, 54% use, and for Black African American women, 41% use. I would not go into the detail of the flowchart, the process mapping of how the overall screening happens, but predominantly what we were hearing from the clinics is that pre-pandemic, patients were being seen by their MEAs before they see their physician, and were getting their mammogram at least reminded, their providers are being scheduled. During telehealth, people were not always thinking about screening, and also patients did not want to go to screening, having to take a taxi or a public transport. So all those were the issues. So the goal of this quality improvement study was that by June 2021, RFPC, Richard Fine People's Clinic at CSFG, will increase the breast cancer screening rate for Black African American women by at least 10%. So that was the goal of our quality improvement study. And so if we think about, increasing the breast cancer screening rate for Black African American women by June 2021, and the goal that we set for ourselves was 10%. This is the root cause analysis. So there were different factors into reduction in screening, from technology barriers to patient barriers, fear of COVID, fear of getting into transport, what the priorities are. And then within the healthcare team, they were not part of the team during telehealth. Maybe QI initiatives were not being done, and providers maybe had limited time. And then the process itself had changed. And so that was another barrier. And then even the prioritization of our resources, as COVID required more resources to be shifted to other from non-COVID care. Non-COVID care saw a drop in metrics. And so these were the countermeasures we thought about, that, because patients may not be aware that they're due. So providing tailored outreach to Black African American women, prioritization, motivation. So patients always have, we know that all aspects of COVID-19, from job losses to food insecurity, hit our communities harder that we provide care to. And so we felt that we could provide a gift card to provide motivation. And then transportation was another barrier. So we provided transportation voucher. And one of the other things we did was that we provided a direct scheduling within the mammogram system. So usually what happens is that the doctor puts in the orders and the imaging center does the scheduling, and then the patient gets called, your mammogram is like on this date. But here, the person who was providing the outreach can actually directly schedule the patients into the mammogram panel, and making these increasing the staff engagement. And so I will draw your attention to effect confirmation. So this is all RFPC patients from September 2020 to September 2021. And you can see that the numbers have increased slowly from the last year to this year as COVID, we are getting a better control of COVID. But more importantly, what the encouraging effect that we were seeing was that numbers have increased more for Black African-American women, which is a very encouraging sign for us. And we are sort of starting to see decrease in the gap. So from 41%, we went to 59%, which is almost our little bit higher than our pre-COVID numbers. And we are not yet at pre-COVID numbers for all our patients, which is around 67 to 68%. So we are still a little bit low overall. And so the next step, hopefully we will be able to do this with other clinics within the system and design a health equity informed quality improvement approach to cancer screening to decrease the gap. Thank you so much.
Great, thank you so much, Dr. Dixit. This poster is now open for Q&A. Are there any questions? Okay, so I have one question. So this is really great. This is a great project. You're showing great results in terms of being able to achieve the stated goal and increase screening, reduce the gap, I would say, of screening for between Black and African American and other patients. Have you looked at, and you mentioned a number of ways in which you increase that. Have you looked been able to look at all at what seems to be the biggest driver in that increase, so that if you are going to replicate this or recommend that people in other clinics replicate this, that maybe they don't have to give the whole gamut of interventions and they can focus their attention on some of the more effective ones?
Initially, we started with transportation because we felt we were hearing from our patients that that was a big barrier. And also from some data that we collected from patients with cancer at CSFG. The other, and that seemed to be one of the things that really helped. But I think what we have heard from from overall, because these were not all sequentials, doing a PDSA cycle with one intervention, we kind of did 2 or more intervention at that one time. So for example, transportation and the gift card were the first 2 interventions that we did. The next intervention we did was more with the direct scheduling of patients within the mammogram panel. So we think that was one of the biggest intervention, that we call the patients, and if they're ready to schedule their mammogram, they get directly scheduled and they don't have to wait for somebody to call them with the appointment. It makes sense because these things are easy to do, but they can be complicated on the operational side. So it did require a lot of coordination between our radiology and the primary care clinic, and driven by the quality improvement staff at ZSFG, the director of quality improvement, and Ghezal, who's one of the co-authors and actually really drives most of this quality improvement work at Richard Fine People's Clinic. Actually, they are the ones spearheading this effort. And so I think the direct scheduling made the biggest difference.
And I think that's really important for us to know and perhaps try to implement wherever we can at UCSF Health. I mean, I think that, and as a ZSFGH, I think that makes a lot of sense and takes out a big sort of an extra step for people having to follow through. Are there any additional questions?
Yeah, I actually do, Stuart. It's kind of similar to yours, but you did mentioned that the transportation voucher was really, you found that really helpful. And I noticed it was from the stipend from the breast cancer SF CAN. If the network wants to continue this effort, where do you feel, where can we continue finding the funding for continually offering our patients the transportation vouchers?
I think that's a very good question. In terms of transportation vouchers, we specifically looked at transportation vouchers because of the COVID issue. That COVID was a big driver of people not wanting to get into buses to get their mammogram, because the perception of risk and real risk is much higher if people have to do that. So that was one driver behind it. So it's possible that it may not be as necessary. The other thing to think about other approaches, for example, like we have a mammogram van that goes out into the community. So thinking of more nimble approaches that patients can actually just go to their primary care clinics and get their mammogram on the day the van is there, versus having to go to ZSFG to get their mammogram. So that might be one approach. So you're right that some of these things will go away as the funding goes away. And so we really have to think about what would be more sustainable. And I think that there are certain components of this intervention that are more sustainable. For example, the changes that we make in clinical workflow as to who orders the mammogram, how does the mammogram ordered, and I think those might be more effective way of doing quality improvement. The second thing I think we wanted to show was that it is really important to think of equity in quality improvement, because quality improvement, everybody is doing quality improvement, but if we don't think about equity in quality improvement, then we can never close the gap. So that was another goal of sort of proof of concept in this design, was that we need to provide outreach, or we have to have specific outreach for groups that are specifically more impacted.
Thank you.
Thank you. Are there any additional questions? Okay, so thank you again, Niharika. It's great that you could share these results since Kara couldn't be here. We really appreciate it. I believe we're ready to move to the next poster. So our next presenter, this poster is from Emily Leiden and will be presented by Emily Harris. This poster is entitled Increasing HIV Screening in a Vulnerable Patient Population via Inpatient Provider Education, Targeted Provider Outreach, and EHR Interventions. So please go ahead, Emily.
Hi, everyone. I'm Emily. I apologize for any background noise. I'm in clinic next to a window that is stuck open, so I'll try to speak up. So I'm one of the internal medicine residents at UCSF, and this project was part of a house staff quality improvement project done at San Francisco General last year. In terms of the background, as we all know, San Francisco General Hospital cares for a vulnerable patient population, and many of those patients are at elevated risk for HIV. Early in the COVID-19 pandemic, the HIV screening rate in the patients cared for in our health system decreased, and this was primarily due to a reduced number of outpatient clinic visits. But admission to the hospital presents an opportunity to screen patients who may be at risk and who may also have low engagement with the healthcare system otherwise. We designed a quality improvement project that involved education of internal medicine inpatient services, outreach to inpatient providers, and optimization of the electronic medical record between October of 2020 and June of this year. And the goal was to increase the number of patients who had been screened for HIV within the last 6 months. we selected a 6-month period just because of the elevated risk of many of the patients. So in terms of our data analysis, we collected demographic information in the data of the most recent HIV test for admitted patients on a monthly basis. And then we also did pre and post implementation surveys of internal medicine residents and attendings to evaluate knowledge and attitudes toward HIV screening. In the middle panel, you'll see some of our results. And the top graph really shows the HIV screening rates on a monthly basis, pre and post project implementation. So the project launch date was October of 2020. And at that point, the average monthly HIV screening rate was around 48% in the hospital. In the subsequent months, the HIV screening rate increased. And for the number of patients screened during the intervention period, which was nearly 1,700, the screening rate was 67.9%. And this represented an absolute increase in HIV screening of 19.5% in the hospital. In terms of our subgroup analysis, you'll see kind of the breakdown of those numbers on the poster here. And we did find that older adults, female patients, and patients who did not speak English, especially patients who spoke Chinese dialects, were screened at a significantly lower rate than the overall population. So in conclusion, our intervention did lead to an increase in HIV screening on the inpatient medicine service at San Francisco General. This increase was nearly 20%. But despite the increase in screening, there were persistent disparities, particularly among women, patients of Asian descent, and patients who didn't speak English. Our suspicions for why this happened are kind of multifactorial. We suspect that there may be some implicit bias on the part of providers. This was corroborated by some of the data from our post-implementation survey, which suggested that people perceived female patients and patients of Asian descent as being at lower risk of HIV. And we suspect that some of the lower screening rates in non-English speaking patients may be due to barriers in consenting and discussing testing with those patients. So I think in terms of those disparities, further investigation is needed, and figuring out ways to implement education for providers for increasing screening is warranted. Thank you.
Okay, thank you, Emily, for an excellent presentation. This poster is now open for questions. Are there any questions for Emily? Okay, so I have one question. So among these 1,700 patients, more or less 1,700, you showed some differences in screening, HIV screening, by race, ethnicity, by gender, and other demographics. And I'm wondering if you looked at any cross-classified demographics, for example, gender by race, ethnicity. And I'm wondering specifically, maybe there are differences for certain racial, ethnic groups in the gender disparity.
The part of our team who did the data analysis, I don't believe has fully finished the analysis of that kind of cross-demographic data. I know that when we were looking at the data early on, it did seem that, for example, elderly female patients of Chinese descent had been screened at particularly low rates compared to the other population. So I suspect that there will be differences when that analysis is finalized. Okay, thanks. Because I think that could be important, getting at some issues of intersectionality, which may show certain groups being at even higher differential in terms of screening. Are there any other questions? Okay, so
let's see. Had another question.
I have a question.
Oh, great. Thanks, Kara.
But I don't know if it'll get too much in the details, but in terms of screening, is that providers placing a lab order or actually verbally asking certain questions? How does the actual screening work?
We, for the purposes of our data collection, counted screening as placing a lab order and having the lab resulted, which is imperfect as a surrogate, because certainly it's possible that providers were having discussions with the patients who didn't have a lab test ordered that was a screening discussion, and they decided not to test based on the patient's low risk factors.
So a follow-up to that would be, in terms of just like research-wise, how would we go about seeing if there was indeed a difference between actually having a conversation and then leading towards the action versus not even having presenting the conversation with the patient at all? Like, what would be the best approach to kind of study that?
Yeah, it's something that we talked a lot about in our project planning. And I think when trying to obtain data in this type of patient population, one thing that came up was like creating a specific dot phrase that could be easily identified and searched in the EMR that providers could put in their notes to just note that they had discussed this with the patient and found that the patient was at lower risk. I think with so many providers involved, it's a little difficult to standardize that and encourage everyone to use it. But I think something like that was the mechanism that we talked about for noting a screening discussion rather than a lab.
Yeah, I think that's a really important point to document, and rather than make an assumption that there was a non lab screening and the person was determined to be at low risk, which may or may not have happened. So now I remembered my other question, and that's whether you've thought about looking at the racial or linguistic concordance between the provider and the patient. And I don't know if you have that ability in the data that you have on these 1,700 people.
I don't think we have the ability to look at that now, but that would be a very interesting question to look into.
Okay, thanks. Any additional questions for Emily? Okay, I want to thank everyone for participating in this poster session, and in particular, Emily and Kara, and I believe that Niharika has left, but I want to thank them for excellent presentations and thank everyone for attending and your questions. And I also want to thank Tiffany Chan for her help in organizing the logistics. So thank you, everyone. And yes, the main session will have our plenary speaker at 11. So I hope that everyone will join for that. Should be really excellent presentation from Dr. Jones. Thank you again. Bye-bye.
Thank you.
Thank you all. Goodbye.